Good morning, guys, or afternoon. This is Paeds lecture number 3 for the USMLE Step 2 CK. This is, again, stuff people get wrong. This is going to be really quick because I have a lot of slides. First thing, you're going to see a kid with ADHD. Clearly, he's going to have ADHD. He's going to have inattentive symptoms, hyperactive symptoms. If mom and dad disagree on whether the kid has ADHD, your next step is going to be to ask the teacher. You need two people in two different settings to say that the kid is having ADHD symptoms to diagnose ADHD. But if mom and dad disagree, ask the teacher. If mom and dad both agree and the kid clearly looks like he has ADHD, the next step is treatment. The biggest mistake people make that if the kid is less than 6 and clearly has ADHD, you are not going to go ahead and give stimulants. You're not going to do that. You're less than 6, you cannot give methylphenidate, atomoxetine. That's not approved. You're going to do behavioral therapy and stuff like that. If they're above 6, go ahead. If the option, if you're not choosing patient management therapy or parent management therapy or CBT, you should have a really good reason. But ideally, that's first line. Second line is these stimulants. And if the mom and dad are really concerned about having stimulants in the home, you're going to go ahead with non-stimulants. Now, a key point to know is they're going to ask you when the kid comes back, what are you going to monitor? You're going to monitor blood pressure and you're going to monitor pulse because obviously it's a stimulant. It's an amphetamine class of medication. And you're going to monitor this and you're going to monitor the weight gain of the kid. If the kid isn't gaining weight and slowing down, that might be because he's taking a stimulant. So that's just something to monitor. All right, so this is the same thing. You can pause and take a look at this. This kind of says the same thing, that atomoxetine is approved above the age of 6. Methylphenidate is approved above the age of 6. Less than the age of 6, you can't give these medications. Again, now another thing I wanted to point out is methylphenidate. That's one use there. Another use is that when they have cancer and they're really depressed and at the end of life and they want to kill themselves and yada yada yada, you need a really quick acting antidepressant, and the antidepressant you're going to use is methylphenidate. And then if they're not eating and they're at the end of their life and they're cachexic and they don't have no appetite, you can use Donna, like the tetrahydro THC analogs. So that's just another use for methylphenidate. It's a really, really quick acting antidepressant. We don't generally give this. This is only in terminally ill people. So anorexia nervosa. If you have anorexia, you just need to memorize a few things and extra things for it. You obviously will recognize, you guys know how to treat. First of all, anorexia obviously can cause bradycardia, and there's mitral valve prolapse as an associated heart condition. Sometimes they're going to ask you to choose cardiac failure or whatever, but know that mitral valve prolapse is associated with this. And then know the criteria for hospitalization. They're going to give you a pulse of less than 60. That's actually also a criteria for hospitalization. A BMI of less than 15, and any of these. This kind of seems very subtle, but if they have any of these, right, if they have a severe electrolyte disturbance on labs, but they look completely fine to you, they have a sodium of 121, they have to go to the hospital. So just know this. Did I skip a slide? Okay, so this is reactive attachment disorder. The kid is going to be neglected. What's going to happen is that he's going to be neglected, and then just read the text. The point I want to make is not of reactive attachment disorder. This is when the kid just doesn't respond to social cues anymore. The point I want to make is on the next slide. You can pause and read this. Okay, so if the kid is neglected and everything, right, one of two things can happen. The first thing that can happen is reactive attachment disorder, where the kid is, let me put on a slideshow, where the kid just doesn't really respond to anything. The second thing that can happen is this thing, disinhibited social engagement disorder. Reactive attachment disorder is when the kid is neglected and then the kid lacks empathy, the kid doesn't respond to care, the kid doesn't show affection. This thing, the second thing, disinhibited. Why is this not going, guys? Disinhibited social engagement disorder. What this is when the kid becomes dangerously friendly. When now this kid has been neglected and now he's craving for attention so much that he's going to be friendly with everyone. He's going to be friendly with the doctor. He's going to be friendly with the nurse and everything. So these are two extremes that can happen: reactive attachment disorder or disinhibited social engagement disorder, that can both happen with neglect. So just know how to differentiate them and know what it means. So the next thing is autism spectrum. You guys all know what autism is. I just wanted to point out this thing I've highlighted in blue, that you screen for this at age 18 months and age 2 years. And these kids get really mad when you change the routine. So that's like a cue. But if the kid likes to eat peas and isn't eating other stuff and otherwise he's fine. If they have specific food interests, that's normal. Don't think that that's autism. For autism, know that you need to have social issues and then repetitive behaviors. You need to have kind of both of them. Screen at 18 months and screen at 18 months and at 2 years. Okay, this is Tourette syndrome. I will assume you already know what Tourette syndrome is. I just want to focus in on the treatment. For the treatment, again, always choose non-pharmacologic therapy if you can have. That's habit reversal training. Anything else, remember the order that you're going to go in. Alpha-adrenergic agonists are for mild cases. Generally, we start antidopaminergic agents first, the VMAT, the antipsychotics, and then alpha-adrenergic agonists. This can only be used for mild cases. Generally, you're going to be starting a VMAT2 inhibitor. So just know the treatment. Another thing is like when you're suspecting child abuse, this is like bruises that have bruises. The reason I put this up here is I wanted to talk about the fractures. There are two types of fractures. There's one fracture that everyone always gets wrong. It's the spiral fractures. So spiral fractures happen when a kid twists. This generally happens in a non-ambulatory child or a child who's just started walking. Again, this is not child abuse. It's common in early walkers. It is not a sign of abuse. The fracture that is a sign of abuse is a femoral, like a metaphyseal corner neck fracture. I've added pictures on the next slide. Look, so this is the toddler's fracture. Okay, let me just clear the screen. This is the toddler's fracture I was talking about. Do you see how there's this spiral right here? This is normal. This happens in sometimes kids that are just starting to walk or barely walking. This is normal. This is not a sign of abuse. This metaphyseal, like this neck fracture, if you see here, like the corner fracture, this is a severe, this is a big giveaway for abuse, as much as like, posterior rib fractures and retinal hemorrhages and cerebral subdural hematomas. That, you know how those are a big giveaway? This is a big giveaway as well. So spiral fractures, you can chill out. It happens in the bottom tibia. It's normal. Don't freak out. Metaphyseal corner fractures, that's a big issue. That's clearly abuse. Again, Beckwith-Wiedemann syndrome, the reason I put this up here is I want to discuss what you do, so how you surveil these guys. Up till the age of 4 years, you're doing an abdominal or renal ultrasound and a serum alpha-fetoprotein. So up till the age of 4 years, you're doing 2 things. From the age of 4 years to 8 years, you're only doing the abdominal ultrasound. And then after the age of 8 years, you're only doing a renal ultrasound. That's very specific. Maybe it's not good, but just remember for the first 4 years of life, you're doing these 2 things. And for the next 4 years and kind of onward till you're doing 1 thing. So I just wanted to focus in on this. Generally, what will happen is these guys will have hyperinsulinism and these guys will have hypoglycemia. So they're going to ask you what to give to the baby after birth with Beckwith-Wiedemann, and you're going to say dextrose. That's what you're going to choose. Because these guys, you know that they're going to have hypoglycemia. Everything else I will assume you already know, but you can just take a look at it if you want to. This is just something, this is a sign of posterior urethral valves. The posterior urethral valves that like are in the males, and then they cause oligohydramnios and Potter sequence, or they can just cause like urinary tract infections, whatever. A good sign for that is called keyhole sign. This is the dilated posterior urethra right here, and apparently there's like valves over here that are blocking it. I'm not sure where they are, but the keyhole sign is kind of the giveaway. So if it kind of looks like a keyhole, it's posterior urethral valves. So this is something that a lot of people get wrong. If the kid is less than 2 years old or 24 months, same thing. And if he has a first febrile UTI, dude, he's getting a renal and bladder ultrasound. What you're going to do is you're going to treat this kid. Okay, first thing, kid comes in, the first thing that you're going to do is you're going to get a sample. If the kid is wearing diapers, you're going to catheterize him and you're going to get a sample directly from his bladder, because when they're wearing diapers, there's a lot of colonization out there and you're going to get a bad sample. If he's not wearing diapers, you're going to get a clean midstream urine, clean catch. Regardless, you're going to treat them, you're going to culture the sample, you're going to treat them with empiric antibiotics and then generally cephalosporin. You're going to wait 2 weeks or such, and you're going to give them a renal bladder ultrasound. Everyone is going to get this. So infants less than 24 months with first febrile UTI, if they're recurrent febrile UTIs of child of any age, so if he's 6 years old, 7 years old, he's having 2 or 3 UTIs, you're going to get a renal bladder ultrasound, and the ones are in here. That's not the point. The point is that I wanted to make is the next slide. When are you going to get avoiding cystourethrogram? First of all, you're going to get it if they're less than 1 month old. That's when it's just really high. So you're going to get a renal bladder ultrasound, and then you're going to get avoiding cystourethrogram. If they have more than 2 episodes of febrile UTIs, for example, they had one, you did renal bladder ultrasound, everything was normal, and they came back a week later and they have another one, they're getting avoiding cystourethrogram. So greater than 2 episodes of febrile UTI, or if you had the first febrile UTI, and remember how I told you were supposed to take the sample was either clean midstream urine or catheterization. If they grow anything other than E. coli, they're going to get avoiding cystourethrogram. So that's just what I've added here. They kind of confuse you this on questions. Don't get confused, and you can pause the video and read it right here. Again, this is just the same thing with detail. It's added some more information at the bottom. I think it's interesting. You might want to take a read. You can pause the video and read it. Okay, androgen insensitivity syndrome and Mullerian agenesis. This is obviously XY. The bottom one is XX. The way you're going to differentiate this is both of them are going to look exactly the same with amenorrhea and everything. Maybe androgen insensitivity syndrome, they might give you that, there's a there's a bulge in the inguinal ligament. That's where, the gonad is stuck, but they generally don't give that. The way you're going to differentiate, at least how I differentiate this, is look for the presence of breasts and look for the presence of secondary sexual characteristics. Androgen insensitivity syndrome. You need androgens to make pubic hair. So these people either have no pubic hair or sparse pubic hair. All right, that's the giveaway. So you're going to look for the presence of pubic hair. Both of them will have breasts and everything, but look for pubic hair. If they have pubic hair, it's Mullerian agenesis. If they have a very sparse or minimal pubic hair, it's androgen insensitivity syndrome. You can pause the video and try to figure out how to differentiate these on your own. Again, just pause the video and read this. I'm not going to explain this. There are a lot of slides to go through, guys. But this is just something, the first one, the one marked in red, is something everyone gets wrong. Okay, cystic fibrosis. I wanted to spend a little time on this. I will assume you know all of this. I want to talk about here, you're going to give nutritional support because these patients are going to be malnourished, and also they're going to be coughing so much, so that expends a lot of energy, so they're going to be malnourished, so you're going to want to feed them. The second thing is you want to do airway clearance with hypertonic saline. The third thing is you want to antibiotic cover them less than the age of 18. You're going to cover them. You're going to cover staph. After the age of 18, you're going to cover Pseudomonas. Another thing is, I've added on the next slide, this is the point of all of this. The point I wanted to make in the previous slide is we also give these people azithromycin. Azithromycin has anti-inflammatory properties, so we give it in cystic fibrosis. That's the first thing. Second thing is hypertonic saline. And third thing is those fancy drugs that you don't remember, but Lumacaftor, Ivacaftor, that they increase the insertion of the chloride channel into the membrane. The next thing is you might have a kid and he might come in at 17. He's had recurrent pneumonias. Again, still suspect cystic fibrosis. If it looks and smells like cystic fibrosis, it probably is. You probably know that screening happens when you're a baby, but you can sometimes miss it. That's what this slide says. You can pause it and read it. The next thing is the diagnostic test for cystic fibrosis. This one, I want you to choose the pilocarpine immuno release assay or whatever immuno they put pilocarpine and they check whether the chloride concentration is greater than 60. That is how you diagnose. That is a test. That is a diagnostic test. So if you have to choose between nasal epithelial ion transport, yada yada yada, or doing the mutation, and if this is in the options, if you're looking for pilocarpine induced whatever, that is the correct answer. Always choose that. Okay, lung abscess again. Okay, so something that a lot of students get wrong is when they see aspiration pneumonia, they try to cover for anaerobes. Don't cover for anaerobes and aspiration pneumonia. If you have aspiration pneumonia, only cover for community-acquired pneumonia organisms, and you're going to cover with what? Amoxicillin clavulanate or maybe macrolide. Only when you have an abscess, then you are covering for anaerobes. So just notice here that ampicillin sublactam, that covers anaerobes. Imipenem, meropenem, these cover anaerobes, and alternate is clindamycin. So only in an abscess you're covering anaerobes. Generally, you're not covering anaerobes if it's aspiration pneumonia. So that's a big mistake students make. So don't be that student. All right, so this is monotherapy for community-acquired pneumonia or aspiration pneumonia. So community-acquired pneumonia, aspiration pneumonia, just treat it. Similarly, don't cover anaerobes. Okay, this is SCFE. This is the femoral head's posterior displacement. The reason I put this up here is, first of all, notice how it's displaced. We're going to contrast this with leg Paeds Step2ck disease. First of all, everyone looks for the overweight and obese boy, but I also want to point out that if you have an endocrine abnormality, for example, you have hypothyroidism, or if you have something which weakens your bones, or you're chronically malnutritioned, or if you have rickets or something which makes your bones messed up, or if you have precocious puberty, think about it, your bones aren't really doing that well, so you are also predisposed to SCFE. So they might give you that, hey, his BMI was within the 50th percentile, but they might give you a history of hypothyroidism, a history of precocious puberty. They also can get SCFE. So if you see this x-ray, this is SCFE. Question is, how do you treat SCFE? That's here. You do the fixation with the nail. Contrast this with leg Paeds Step2ck disease. Again, this is the avascular necrosis. They're going to hold their leg in abduction and whatever. And how you're going to treat this? You're going to treat this conservatively. You're really not going to do much for these patients. So contrast this with SCFE. You're not going to do much for this. You're going to manage conservatively and refrain from weight-bearing exercises. For SCFE, you're going to go ahead and fix that. So this is the cystic fibrosis slide that's here. It should have been there, but it's here. Again, we already talked about all of this. You can pause it and read. And upper lobe bronchiectasis is kind of an unusual finding. That's kind of very specific. Not very specific, but it kind of points towards cystic fibrosis. So if you see upper lobe bronchiectasis in maybe a 30-year-old dude who's had mildly history of pneumonia, you can start thinking that that this might be undiagnosed cystic fibrosis. Again, so this is the half top of this picture has been eaten off, but look at this full volume loop, right? If you see this flow volume loop and you're not saying obstructive sleep apnea, then you need to go and do your flow volume loops again. How you'll know this is look at the lung volumes. The lung volumes, this side is higher, so the lung is retaining more air. That means that it's probably an obstructive disease. And this scalloped edge, that's what they always like to show you. The scalloped edge with a prolonged expiration is asthma. The reason I put this up here is asthma has a normal or high DLCO. That's kind of unique. Not many things cause a high DLCO, and asthma is one of them. So just keep that in mind. Another thing is, this is how you diagnose. Do a PFT. If you still suspect, give a methacholine challenge. This is never done. If it's positive, which is a less than like a 20% decrease in the peak expiratory flow, that's asthma. Or you can give albuterol, and if there's a 12% increase in FEV1, that's asthma. But no one really does the methacholine challenge. Just know that's like something that you can do. And just know the cutoffs. It's 20% for this and 12% for the FEV1 increase response to albuterol. This is just another thing of asthma. You can pause the video and take a look at it. The reason that this is up here is when do you intubate in asthma? If the PaO2 is going down, obviously that means saturations are falling. So the point I want to make is have a low threshold for intubation. If PaO2 is falling, if pH is rising, if PCO2 is rising, that means that this guy's impending respiratory failure. You want to intubate them. This is technically the indications for intubation. Another thing I want to point out is you can give magnesium. Magnesium is like just one of those cool drugs that we memorize, but you can also give magnesiums in refractory asthma. But just know when to intubate and have a low threshold of intubation. They're going to tell you that continue non-invasive positive pressure ventilation. Don't do that. They should be in a respiratory alkalosis. If they're becoming like normal between 7.35 and 7.45, that means that their bleeding is slowing down, their respiratory muscles are exhausting. Intubate those guys before they become like normal acidemic, if that's a word. Leach-Nyhan syndrome, everyone knows this. HGPRT, everyone knows self-mutilation, everyone knows everything. Just remember the treatment is allopurinol and adequate fluid intake. Allopurinol is the xanthine oxidase inhibitor. It's going to increase the secretion of the thing. And another thing is that they're going to ask you what's the buildup of. The buildup is the PRPP is building up. Everyone kind of like forgets that, but PRPP is building up, and then obviously the hypoxanthine and guanine is building up, because that's the thing we're phosphoribosyltransferasing transferasing. But PRPP is building up, and just know the treatment for this. So again, know how to differentiate between Marfan and homocystinuria. That's coming up on the next slide. That's this. The only way you can really differentiate these is they're going to tell you that Marfan's kid is an honor student. The homocystinuria kid is not really doing too hot. The other thing is homocystinuria will have this megaloblastic anemia. I will do this in purple. And they will have a fair complexion, and they will have a downward dental dislocation. They will have thrombosis and intellectual disability. So this is how you differentiate them. Really, you have to be looking for this. This should be on your toes, on your fingertips or whatever. But this is what you should be looking for. The next is, this is kind of a sign for Marfan's. If you do this in your hand, like your thumb isn't popping out of the end, so you don't have Marfan's. If you do, I'm sorry. The thing is, another cool sign on the bedside is you take their wrists and then you hold your hand like this, and they should do it on their own hand. So they're going to put up their hand, and you tell them take your other hand and grab around your wrist. If you see like my fingers aren't really touching one another, if their fingers are touching, or if they have like a lot of space, and you can pass two fingers underneath that space that's created, like suppose their fingers were really long, suppose they're like this, if you can pass your own two fingers underneath that, that means that they probably have Marfan's. It's just a cool bedside test. It's good to know, I guess. This is myotonic dystrophy. You can pause the slide and take a read of this. I'm sorry, I just really have a lot of slides today. But the mnemonic in first aid, if you guys remember, was CTG, cardiac topy, and gonadal atrophy. These guys also generally have type 1 diabetes. It's probably written in here somewhere, but just you can pause the video and read this. Everyone doesn't know this. This grip myotonia is pretty specific. And another thing is milkmaid's grip, which is another buzzword. That's for Sydenham chorea. But you can just take a look at this. Everyone gets myotonic dystrophy wrong. So just please know this. Another thing is for Fragile X, they'll ask you what the cardiac complication is. You're going to say mitral regurg due to mitral valve prolapse. Mitral valve prolapse is just kind of one of those things that shows up anywhere. It showed up in anorexia previously. It shows up in Marfan syndrome. Marfan syndrome also has aortic root dilation leading to aortic regurg. So in Fragile X syndrome, this mitral regurg also shows up. Another thing is galactosemia. I put this up here because you guys will know everything. E. coli, sepsis, cataracts, yada, yada, yada. Treat with soy milk. I just wanted to point out that these people will generally have a conjugated hyperbilirubinemia because, well, it's just not being excreted, but they might have an unconjugated hyperbilirubinemia because there might be hemolysis, but just don't really get tripped up in the type of bilirubin. Try to recognize it from all the other symptoms. Okay, this is, I think, the last slide. I think I sped through everything today. How will you know if it's a disorder of fatty acid metabolism? When you get really hungry, right? When you get hypoglycemia, your body freaks out and makes ketones. So you have like a ketosis. That's, what the keto diet is all about, going into ketosis. These kids with, and how do you get these ketone bodies? Well, you're breaking down fatty acids. You're breaking down your fat, and that's how you're burning your fat. Now, the thing is, if you have a disorder of fatty acid metabolism, you're not going to be able to break down fat, and by extension, you're not going to be able to make ketones. So if you have a hypoketotic hypoglycemia, generally when you have hypoglycemia, you should have an increase in ketones. If you have a hypoketotic hypoglycemia, that is going to be a tip off to you. They're going to give you like ketones like 0.03, and they're going to give you the normal limit, which is going to be high. You're going to realize that, wait a minute, this guy isn't metabolizing his fat. Then it can be one of two things: this primary carnitine deficiency or MCAD. This is hypoketotic hypoglycemia here, and this is hypoketotic hypoglycemia here. That's going to be the tip off. Generally, they're not going to want you to be able to decide between these two, but for MCAD medium chain, you're just going to give like long chain stuff. I've forgotten the treatment. You can look it up, but just know hypoketotic hypoglycemia is a very unusual phenomenon. Okay, I think that was everything, guys. Oh, no, there isn't. That's not everything. Kawasaki, that's the only thing we treat with aspirin IVIG. The reason I put this up here, and you probably know, is that if you're taking IVIG, live vaccines are contraindicated for a year. That's the first thing. Second thing is start within 10 days. If you start after 10 days, these guys get the coronary artery aneurysm and they die. And the third thing is, before you're starting treatment, you can get an echo right now. You're going to get an echo right now to see whether like there's any like coronary artery aneurysm, and then you're going to get an echo after a while, after 6 to 8 weeks, to see if they're going to be developing this aneurysm that you're going to want to monitor. So yeah, okay, that's everything, guys. We sped through a lot, but hopefully you guys learned something. Hope you guys are going to get some questions wrong. If you guys have any questions or anything, ask them in the comments, even though no one really watches these videos. But yeah, see you guys in the next Paeds video or the EKG video. Bye bye.